Hi, my name is Dr. Jed Sieve. I'm an assistant professor at Nova Southeastern University in the Center for Psychological Studies, and I'm pleased to be able to speak to you today about the fundamentals of exposure and response prevention, a tailored form of CBT for obsessive-compulsive disorder. And what I'd like to talk to you today about in particular, to give you a little bit of an outline, is I'm going to spend some time talking about what OCD is in understanding OCD from a CBT perspective. And that's just to get everybody on the same page, but it's also because the treatment, ERP, is so specifically tailored toward the understanding, the conceptualization, and the experience of OCD. I find that it's very helpful for treatment purposes for therapists especially, but as well as the patients, to really understand what's going on with their OCD, what OCD is, how it works with a little bit of sophistication in order to facilitate effective treatment. Then after reviewing what OCD is, what it's like, and how we think about it, I'll talk to you about exposure and response prevention. We'll review some of the techniques and go over how it's actually implemented, the structure, the form, the techniques, the sessions, and that sort of thing. And then finally, we'll spend a little bit of time at the end on some of the challenges and nuances and subtleties of implementing ERP with some of the difficulties that clinicians often encounter, and some things that might not be completely obvious just from hearing about and learning about how to actually implement which techniques when. And so to start off with, I want to review the DSM criteria for OCD and highlight several points about them. So to get a diagnosis of OCD currently in the DSM, one does not have to have both obsessions and compulsions. One can have either obsessions or compulsions, and I'll return to that in a minute. Because it's very uncommon for somebody to have one without the other, especially obsessions without compulsions. And it may not even be the case that people do. And I'll get back to that in just a moment. But to define obsessions, this is taken basically right out of the DSM. Obsessions are recurrent and persistent thoughts, images, or impulses that are experienced at some time during the disturbance as intrusive and inappropriate, and that cause marked anxiety or distress. And so it really, obviously recurrence is important here. It's not something that just happens one time. And it's persistent, but it could be really any kind of internal experience that comes to somebody, especially an internal cognitive experience, whether it's an impulse, the urge to stab somebody, whether it's a thought, an image, a distressing image that comes to somebody. They find it intrusive and inappropriate, and it causes a lot of anxiety. Functionally speaking, what makes an intrusive, persistent thought like this an obsession has probably the most to do with the anxiety and the distress that it causes. There's some differences here if you're thinking about intrusive thoughts in other disorders, for example, or persistent thoughts. For example, worry in the context of generalized anxiety disorder may be recurrent, it may be persistent and hard to get rid of, but it's not intrusive in the same way, for example. The second part of obsessions is that the thoughts, impulses, or images are not simply excessive worries about real-life problems. That may also distinguish it in many cases from generalized anxiety, kind of intrusive worry thoughts. The person attempts to ignore or suppress such thoughts, impulses, or images, or to neutralize them with some other thought or action. And you probably are aware of the fact that attempts to try to get rid of your thoughts doesn't help a whole lot, and we'll return to that as well. Usually that has a paradoxical effect, actually, and it keeps the thoughts around longer. This is another part of the definition of obsessions, though, that distinguishes it from generalized anxiety kind of worries in the sense that neutralization, efforts to neutralize the thoughts themselves, are most associated with OCD kind of intrusive thoughts and obsessions. And finally, the person recognizes that the obsessional thoughts, impulses, or images are a product of his or her own mind, not imposed from without, as in thought insertion. And essentially, this is a differential that's trying to keep us from misunderstanding psychosis. If somebody is having intrusive thoughts, but they believe there's thought insertion, that would give you certainly a lot of pause in thinking that it's an OCD kind of obsession as opposed to perhaps some sort of psychotic symptom. And so those are obsessions. Note that obsessions are ego-dystonic as opposed to syntonic, which means that people experience them as not like me. It's not who I am. I don't want to be thinking these thoughts. It's unpleasant. I just can't stop them. It doesn't feel like who you are when you have these kind of obsessions in most cases, again, as opposed to something like generalized anxiety, where people may have persistent worry thoughts they can't get rid of and even cause them distress, but they will very often say something like, I'm a worrywart, I worry all the time. It's not that the content of the thoughts is so foreign to me or feels so not like me. It's the persistence and some of the other factors associated with those thoughts. In terms of compulsions, compulsions are defined by the following two criteria. The first is that they are repetitive behaviors. They could be things like hand washing, ordering, or checking, or mental acts. And we're going to return to that a lot. Or mental acts is very important. It means that a compulsion can be mental as well. Just because something is a thought doesn't automatically make it an obsession, and we'll think about and talk about a little bit what you do with those and how to distinguish them. But it could be repetitive behaviors or mental acts, praying, counting, repeating words silently, that the person feels driven to perform in response to an obsession or according to rules that must be applied rigidly. And it's very often the case that with people who have OCD, the compulsions are very functionally associated with the obsessions in the sense that compulsions, and by the way, I'll sometimes use the word rituals interchangeably. So by rituals, compulsions, I mean the same thing. That the person's rituals or compulsions are done in response to an obsession. The obsession causes distress. Often that's anxiety or fear, but it could be disgust. It could be another emotion as well. It could be a combination of emotions. But it causes some kind of distress, again, usually anxiety. And then the compulsion or ritual, mental or otherwise, is done in response to that. Very often it's in response to that in the sense that it's designed to eliminate anxiety in some way. That can be because it's going to prevent some sort of feared outcome, or it could be in a less straightforward kind of way. Tapping several times might be a compulsion for somebody, even though there's no clear relationship between that compulsion in terms of what power the tapping has to do in preventing some sort of negative outcome or actually undoing the ritual, the obsession per se. The second piece of compulsions is that the behaviors or mental acts are aimed at preventing or reducing distress, and I was kind of saying this before, or preventing some dreaded event or situation. However, these behaviors or mental acts either are not connected in a realistic way with what they're designed to neutralize or prevent, or are clearly excessive, which is what I was saying before. It may or may not be sort of, when somebody hand washes, it certainly makes sense. It might be really excessive, but at least it makes sense that the hand washing is going to prevent some feared thing about contamination. You can see that there's a relationship between the content of the compulsion and the content of the obsession. That does not always have to be the case. So I mentioned before that according to the DSM now, you can have OCD with only obsessions or compulsions. You don't need both. And there's a term that you may have heard before called pure O, or pure obsessionals, pure obsessionality. And that refers to, supposedly, a group of people who don't have compulsions and do have a lot of obsessions. And so some commonly thought subtypes of OCD where that was thought to be typical, or at least not very rare, would be things like religious obsessions, where people obsess about sinning or offending God, those kinds of things. And sometimes people say, well, I'm not ritualizing in any way, and they're thought of as pure O. Sometimes people have sexual obsessions, bothersome, intrusive sexual thoughts that they can't get rid of, that are not pleasurable, and the same kind of thing. What's become recognized more and more over the past, I'm not sure how long, over the past decade, let's say, is that it may be a bit of a misnomer. If we really consider and do a good enough job assessing people who are saying that they're not having, or not aware of having compulsions, what we usually find is that there are mental rituals and mental compulsions. There are times where they're avoiding things, or in their mind where they're fighting the image, or replacing bad images with good images, or replacing bad thoughts with good thoughts, bad and good all in quotation marks there. And it's probably the case that fewer than 1%, maybe 0.5%, maybe even less, maybe nobody, actually really has pure O. And you'll see why that makes sense actually as we go and we talk about the CBT model for OCD. Other criteria include, for adults, this is not the case for kids, but for adults it has to be recognition at some point during the illness that the obsessions or compulsions are excessive or unreasonable. Again, if there's no insight at all at any point, that's starting to make us think that it's a little bit more of a delusional thing. So I'll show you in a moment that the degree to which people with OCD believe that their thoughts are reasonable, there's a spectrum about how much people believe that. But if somebody really never at any point had any insight into the fact that their obsessions or compulsions are excessive or unreasonable, that makes us wonder about whether it's delusional as opposed to an OCD kind of presentation. It has to have distress or interference. That's the criterion that we all know and love from pretty much all the disorders. It's not accounted for better by another disorder, and it's not due to substance use or medical condition. There's a specifier for poor insight. And the specifier for poor insight, again, as I just mentioned a moment ago, you have to have had insight at some point, at least some degree of insight. Otherwise, we're thinking it's not OCD. It might be delusional. But people would be specified as having poor insight if during most of the time during their OCD episode, they don't realize that it's excessive or unreasonable. How much, in fact, do patients with OCD view their fears as unreasonable or reasonable? These are some data from the DSM-IV field trial. This is a study published in 1995 by Edna Foa and colleagues. And what you see here on the y-axis are the percent of the patients in the trial who endorsed these various kinds of answers to the question about how much they see their views basically as reasonable. And what you see is that only 4%, all the way on the right over here, only 4% of the patients in the field trial were certain that their fear would occur. So that'd be very low insight, almost to a delusional level. And what you see is then there's kind of a bell curve looking curve showing how much people did believe it. So over here, people are mostly certain the fear would occur, their feared consequence would occur. People who are uncertain, people who are mostly certain it wouldn't occur, and people who are sure it would not occur but are still so anxious about it. And so the messages that I'm trying to convey to you about that is that it's a very, very small number of people who really have fixed beliefs and really have very low insight in the sense that they are certain that if they, say, wouldn't ritualize, their fear would come to fruition. That's only 4% in this trial. But I also want to let you see that there is almost a bell curve kind of distribution of insight where there's a range, and patients with OCD have more or have less insight. And of course, when people have less insight into how reasonable or unreasonable something is, that obviously poses a therapeutic challenge sometimes. People who really are closer to being mostly certain that the fear would occur if they don't ritualize are going to have a much more difficult time not ritualizing, and you may have to spend some time working on those thoughts and or developing some strategies to help them, help their motivation, et cetera. In terms of some epidemiology, the lifetime prevalence ranges from 1 to 3%. Let's call it about 2. The most recent studies, I think, are around that amount. So about 1 to 3% of people will, at some point in their lives, meet criteria for this. That's not so tiny if you think about how many people were in your classes in college and high school and everything else. You probably knew many people who had OCD, or at least will have OCD at some point. Maybe you weren't able to recognize it because sometimes people can keep it under wraps. 12-month prevalence around 1%. The age of onset tends to be younger for males than females, but there aren't big gender differences. And if there are any gender differences by adulthood, they may even go in favor of women having a higher rate. But let's say about the same ratio, men and women meeting as adults for OCD, but it tends to start younger in males. So for example, about a quarter of males, maybe a little less than a quarter of males, had their onset of OCD before the age of 10. It's much lower than that for females. But by adulthood, the girls turning to women have caught up, so to speak. The course is chronic if it's untreated. This is not episodic in the same way that something like depression might be. It's not to say it doesn't wax and wane, but it tends to be pretty chronic if untreated. It's associated with a lot of distress, high rates of role impairment. There are lots of studies that demonstrate that. In fact, the World Health Organization identified it as a top 10 cause. I think it might have been 10. I'm not sure about the exact number, but it was a top 10 cause of years lived with illness-related disability. So there's a really high cost. And one of the, from my perspective, rewarding things about working with people who have OCD is that you have people who are so distressed and so impaired and have lost so much to their disorder, and yet the treatment can work and is so efficacious if they can do it, that you can really see people turn their lives around from being in a very dark, very distressed place to really making great improvement. And I'm going to try to tell you some about that. So if I were going to recap then what I want you to hear up to now, I want to emphasize the functional relationship between obsessions and compulsions, and that obsessions are intrusive thoughts, images, or impulses that are disturbing or inappropriate. They cause anxiety, fear, other emotions too, but we're going to speak mostly about anxiety and fear. Those are the things that cause people to get anxious. Compulsions are all the things that people do to neutralize those thoughts or suppress the obsessions or prevent some kind of feared thing. Functionally speaking, a compulsion, aka ritual, is something that the person engages in that reduces their anxiety. So it all depends on what happens to the anxiety. Intrusive things that they think about that they don't want to think about and cause anxiety, those are obsessions. Things that they do or think volitionally in order to reduce anxiety in some way, those are compulsions or rituals. And it's going to be a very important distinction because we're going to treat obsessions and compulsions quite differently, as you'll see. And so at the risk of beating a dead horse a bit, compulsions can be overt or they can be covert. They can be mental rituals, and it's a challenge because patients are not always aware of some of the things they're doing in their head to try to neutralize the thoughts, et cetera. Just an example so you can picture it. I've had patients who have had intrusive images of bad or dangerous or horrible things happening to a loved one. I'm thinking of somebody in particular who would think of this about her mother and her sister. And when she would have these thoughts, she had a variety of mental rituals she would engage in. She would sometimes sort of like wipe the thought clean, imagining it being like a whiteboard. She would sometimes visualize sort of a protective ring going around the person who they loved, and that sort of clicked it for her, if you will, and made her feel like she was less anxious. OCD is heterogeneous. So the obsessional content and the compulsive behavior, of course, as well, of two different people who have OCD can look really, really different. And that's the case even for people who have similar kinds of OCD. You can have two different people who have some form of contamination concerns, and they really might be triggered by two totally different things, and their feared consequences might be two totally different things. So there are some subtypes that we talk about in the literature. And studies using factor analysis and other kinds of methods have shown different, slightly different versions of what I'm about to show you, but roughly speaking, we see about 4 subtypes or categories of OCD. And it's not the case that any one person only has one subtype. People often have symptoms that cross these borders, and people's symptoms can change over time. So you can have somebody at age 16 who is really concerned about contamination, and later on it's not contamination anymore, it's something else. But it's useful to know about these subtypes. One subtype is what we would call washers. So people who have contamination obsessions of all different sorts. Sometimes it could be about sickness, kind of germ contamination. Sometimes it could be sticky substances and residues. It could be various kinds of contamination. I'll actually give you an example in a little while that's a really sort of off the beaten path version of this. With cleaning compulsions. So that's probably the prototypical case in people's mind when they hear about OCD. They're thinking about people who are worried about being contaminated and washing and Purelling a lot. Checkers, when we say checkers, we're often talking about people who have accidental harm obsessions. So they have thoughts like, what if I didn't turn off the stove well, or there's gas leaking? What if the door is not locked? Those kinds of obsessions, and some kind of accidental harm could happen. And then they usually engage in a lot of checking compulsions. They might check the door, check the stove, those kinds of things, really to prevent those kinds of harm things from coming true. A third category, again, with broad strokes here because there are important and useful distinctions to make within each of these categories sometimes. But there's a category of unacceptable thoughts. There are some people for whom the thoughts themselves are really troubling. And so especially people who have aggressive impulses or obsessions, so people who have obsessions about stabbing their kids or something like that, where it's not accidental passive harm, it's like, what if I would, when I'm cutting vegetables, what if I'd stab my kid, or an image of doing that. Religious obsessions are often in this category too, so people have intrusive blasphemous thoughts, people who are in church and have blasphemous images of Jesus in some sort of inappropriate position. Lots of thoughts like that, thoughts of cursing God, those kinds of thoughts. So it's not uncommon, although it's not ubiquitous either, with scrupulosity, which is the type of OCD related to moral and religious concerns, for people to be troubled by unacceptable thoughts, as well as sexual obsessions. Sometimes people have intrusive sexual obsessions. Could be things like of being a pedophile, of molesting kids, of aggressive kind of stuff. Basically, obsessions indicate that we're not talking about fantasies. We're talking about intrusive sexual thoughts that they don't want to have, they try to get rid of, etc. So unacceptable thoughts is this category. It may be useful to be aware of a distinction in the literature. It's sometimes referred to as autogenous versus reactive obsessions. And forgetting about those terms, the point I want to bring out is that for some people with OCD, the thought itself is something they want to get rid of. They're bothered by having the thought. Somebody who has what they perceive and what they interpret as blasphemous thoughts, somebody like that may try to stop that. The main thing they want is not to think that thought. So it's the presence of having that thought that causes so much distress. But there are some other people with OCD where the thought itself is not scary. It's not even super unpleasant, except that it triggers an awareness of something terrible that could happen, and then they engage in compulsions to avoid that consequence. So for example, if somebody has an obsession about being contaminated, it's not really per se that they don't want to have thoughts that they could be contaminated. I'm sure that's true also, but the problem is not I'm having a thought that's a horrible thought to have. The problem is I might get contaminated and then whatever the fear is. And so having the obsession makes them aware of a consequence they want to prevent. What they want to prevent is the possibility of their feared consequence, not the occurrence per se of the thought. That's something to keep in mind as we go as well. And then the fourth category in many of these studies is a category about symmetry, completeness, not just right kind of obsessions, with ordering and arranging and other kind of compulsions. And this is the category where sometimes, although not always, sometimes there isn't really a clear-cut feared consequence associated with it. Sometimes people just don't feel right. They feel the need to do some sort of compulsion. Maybe the fear is that if I don't do this, I won't be able to tolerate my anxiety, or the anxiety will never go away, or I'll go crazy. But it's not usually associated, or at least it's not always associated, with like, oh, somebody's going to die or something terrible is going to happen if I don't do whatever it is that I'm feeling a strong urge to do. So it's an incompleteness and not just right feeling. Sometimes it has to do with symmetry and ordering and arranging. The last category that I'm not going to talk about really at all today after this point is hoarding. Hoarding right now is a subtype of OCD. Probably in the DSM-5, it's going to be a separate but related disorder in the obsessive-compulsive spectrum. There's mounting converging evidence. It's both biological evidence, genetic evidence, behavioral evidence, all sorts of evidence that suggests that although hoarding can sometimes be a symptom of OCD, and certainly can be related to OCD, it's not just a subtype of OCD. It's its own thing, and there's some important differences that I'm not going to go into. But the point for our purposes is that if you were treating hoarding, what I'm going to tell you today is probably not sufficient. You would really need to do some hoarding-specific kind of interventions as well. So I've alluded to or told you about some common kinds of obsessions, just to throw out a couple of other less common ones to be aware that there's really no limit. It's infinite what your OCD can latch onto in terms of fears and obsessions. Sometimes there are people who have fears about losing part of their essence. They obsess about if I touch certain things or if I throw away certain things that I'll somehow lose some of my essence. Sometimes people have contamination having to do with things like geographical region or racial or ethnic things, and it's not necessarily a sign of racism either. In fact, I'm thinking of a patient who had basically contamination-related concerns when interacting with Asian American folks, and she was Asian American herself. So whatever you would make of why and how that would develop, OCD can sometimes manifest in some different kinds of ways. I also want to make the point that the forms and frequencies are fairly similar to what I'm showing you here, are fairly similar across cultures, maybe surprisingly so, but the fears in terms of content can be culturally specific. So for example, in 1960, somebody with OCD wasn't having anywhere, but somebody in Miami, Florida was not having obsessions about contracting AIDS. That wasn't the content, even if they had contamination obsessions, and it's for obvious reasons, people weren't concerned about that then. And nor were they having obsessions about swine flu and bird flu and SARS. As different things come up and come to people's awareness and the culture's awareness, et cetera, those become important issues and important issues to individuals, and their fears can latch onto those things. Well, it's not just the type of contamination, it's no different with anything. So in certain cultures where religious ritual purity is an important and emphasized aspect, part of their culture and part of their lives, then OCD frequently latches onto those kinds of things. So you'll get people who obsess a lot about ritual purity and religious kinds of things related to it. You don't see that as much in other kinds of cultures and other kinds of religious groups because that's not important. So the thing I'm trying to say is that the culture, religion is one example of that, but all kinds of things can be part of the culture. The culture will influence the expression in terms of the content of the obsessions, the fears, and maybe some of the behaviors in terms of rituals. But you do see these kinds of categories across different groups. Okay, so that's what I want to tell you in terms of what is OCD. And now we're going to transition a little bit over into how do we conceptualize OCD from a cognitive behavioral perspective. And I'll try to give you a little piece of both, a cognitive piece, a behavioral piece, and then we'll blend it all together before we talk about how to do treatment. So have you ever had one of these kinds of thoughts? Thought of poking something into your eyes, a sudden urge to kick a baby, wishing someone close was hurt or harmed, an image of your best friend dead, an urge to insult a friend for no apparent reason, unwanted sexual impulses or images. Who has intrusive thoughts? And I can't ask you this in person now, but I'm thinking that whether it's these exact thoughts or some other variation, most of you are able to recall thoughts like these, like inappropriate, weird thoughts, even bizarre thoughts that sometimes come into your head. And so it turns out that these kinds of intrusive thoughts are pretty much ubiquitous, pretty close to ubiquitous. Everybody's got them. And not only that, but in most studies, it's very difficult, if not impossible, to distinguish the intrusive thoughts that people with OCD have from the intrusive thoughts that people without OCD have, just on the basis of how bizarre the content is. So it's not really that people with OCD are having weirder thoughts than people without OCD. People without OCD all sometimes have intrusive, bizarre thoughts like these kinds of thoughts. And you're probably aware of the fact that when you try not to think about something, it doesn't work too well. So there's, the white bear is often used to illustrate this. You weren't thinking of white bears before. If I instruct you not to have an image of a white bear come into your head as I continue talking to you, you're probably going to have that recur more often than had I not mentioned that at all. And that's because there's a paradoxical effect, and at best there's no beneficial effect to engaging in a lot of thought suppression. So what then, if everybody does have intrusive thoughts, it doesn't really help too well to try to push them out of your mind. What makes intrusive thoughts problematic for some people, aka people who end up with OCD? So we're all thinking some of these thoughts, and some of us are just okay with it and move on with our lives. Others who develop OCD end up having these recur all the time and obsess about them and end up engaging in a lot of rituals and behaviors to try to neutralize, prevent them, et cetera, et cetera. And let me try to illustrate with an example. It's a little bit of a contrived, silly example, but it'll make the point. Imagine that I'm standing on the train tracks, not on the tracks, on the platform waiting for a subway train. And I'm standing there, it's part of my commute, and there's a baby in a stroller right near the edge of the track where the parents are standing there. And I get the intrusive thought, what if I would shove that kid in front of the moving train? Kind of a weird thought. Don't know exactly why I would have that thought. But what I would probably do if I did have that thought is I'd think, that's kind of weird, and I'd move on with my day. I'd continue to think about whatever else I was thinking about. I'd continue to do with whatever else I was doing. And by the time I got to work or home from work, I'm thinking I won't even remember having had the thought because it didn't register as particularly important. The same way that you see lots of stuff on your commute to and from, and you don't remember at the end of the day unless it was important enough to pay attention to. Although you don't remember the flower that you happened to pass 3 blocks ago, even if it was a nice flower. What would happen instead, though, if my reaction were, oh my God, why would I think such a thing? Does that mean I would do it? I don't think I want to do it, but why would I have such a thought if I weren't going to do it? Maybe I'm at risk for losing control. Even if not, what kind of a sick person would have a thought about pushing a perfectly nice, strange baby in front of a train? Like, what kind of a sicko am I? And you would start to go like that. So you can imagine in this contrived example at least a little bit of anxiety if I were thinking those kinds of thoughts about my initial intrusive thought. Imagine as well that because of this, I thought to myself, hey, listen, I don't think I want to do it, but why would I have such a thought? Maybe I will do it. I better just step back over here. And so I step back away from the edge of the tracks. No big deal, no skin off my back. The train's going to come. I'm still going to get on there. Maybe I won't have such a good seat. But it kind of works in the moment. I don't feel anxious anymore. It seemed like there was a very small chance that I would actually shove this kid in front of the tracks, but why take a risk like that? What's the harm of standing a little bit further back? Okay, end of story, no problem. On my way tomorrow, though, I come back to the tracks again. I come down the stairs, and I start to walk over to the edge where I usually stand, and I kind of get like a little surge, a reminder, a little feeling like, oh, that thing yesterday. And I think to myself, you know what, I'll just stand back here, and I'm good to go. I'm fine. This goes on day after day, week after week, and at some point, I'm walking down to the platform, and I meet up with a friend of mine, and I've been avoiding this for 6 weeks, 8 weeks, whatever it is, and he starts to walk toward the edge where we would normally stand. And I'm embarrassed to say anything about not wanting to stand there or my anxiety, so what I do is I suck it up and I go. You can imagine that I'm getting anxious somewhat. You can imagine some of the physiological symptoms of anxiety. I don't know how much it would be. This is sort of, like I said, a contrived case. But I've sort of built up my anxiety by avoiding the whole time. And what we kind of have is a chain where it all started with an intrusive thought that I took very seriously instead of dismissing, engaged in avoidance kind of behaviors, and now I've actually got a problem with some anxiety about something that wasn't a big deal for me before. If I'd illustrate that in pictorial form, it starts with a thought up at the top, that's the top circle, the urge, let's say, to push the kid in front of the train. I then make some interpretations that actually give that some amount of power. I have thoughts like I might lose control, I want to do this, good people don't think like this, whatever the content exactly is, which causes me distress, anxiety mainly. I engage in avoidance or rituals in response to the anxiety, such as keeping away from the tracks, maybe checking, maybe reassurance seeking, asking other people, that sort of thing. And in the short run, that works for me, but in the long run, it builds up the problem. I start having this thought more often, and I become more distressed by it, so it perpetuates the cycle in the long run. So there are several kinds of cognitions, thoughts and cognitive styles and metacognitions that perpetuate the cycle in that they contribute to the kinds of maladaptive interpretations I make in response to the original thought. Thought-action fusion refers to the tendency that people have to varying degrees to think about thoughts as being more equivalent to actions. So there's one type of thought-action fusion that's moral thought-action fusion. People who hold the belief to some degree that thinking about something bad is morally equivalent to doing it. You may be familiar with President Carter's famous quote or famous reference to the passage in Matthew about committing adultery from lusting after another woman in his heart. That is sort of attaching significance, moral significance to the lust, the thought, the desire, in some way equivalent to actually acting on it. There's also likelihood kind of thought-action fusion where sometimes people believe that if you say something, if you think something, it makes it more likely for it to actually happen. It's a little bit superstitious. And if you think that sounds a little bit crazy, I'm going to invite you to think of somebody you care about very much, a child, a spouse, a parent, a family member, and write down on a piece of paper, I wish that my daughter so-and-so, or I wish that my mother so-and-so dies in a fiery crash today. And there are a lot of people who get a little uncomfortable with that. So that can give you a flavor of what I'm talking about here. Inflated responsibility is a big piece of this. People who feel like if I could prevent something and don't prevent it, it's as bad as if I actually do it. So if I have an intrusive thought that maybe I left the stove on, and I don't go and check it, when am I lazy? I can just go downstairs, I can just turn back and go and check it, then it's as bad as if something bad in fact does happen, it would be just like I was responsible for doing it on purpose. People have intolerance of uncertainty. This is something that's common with generalized anxiety as well, where there's an effort to try to prove that things are safe, and a big discomfort with not knowing for sure. And so lots of people are pretty darn sure that it's unreasonable, that their obsessive fears are not going to happen, and yet it's possible. But what if, but what if, but what if? Some people call it the doubting disease because of that. And of course, we all engage in things that carry some level of risk, even with a terrible consequence all the time. It's how we live our lives. If you cross the street, you might get hit by a car. If you go driving, you might get into an accident. There are a lot of things that have some non-negligible probability of something really terrible happening, and we tolerate that risk because we really can't be certain all the time that everything is perfectly safe. And people with OCD, though, have a lot of trouble in the domain of their obsessions with tolerating the what-if possibilities, even when they know it's really unlikely. That's one reason you can have medical doctors who are afraid that they could contract HIV from touching the doorknob in a public bathroom. They know the science of it. They know it's, as far as we know, impossible or incredibly unlikely, and yet there's the what-if possibility. There's an overestimation of threat that's common. Sometimes the overestimation of threat can be about the probability of something happening. So some people with OCD see things as more likely to happen than they really are. But sometimes it has to do with the cost. If it would happen, how bad would it be? They overestimate how bad it would be. Related to a couple of these is the notion that people with OCD seem to default to thinking that things might be risky, might be dangerous, unless they can give themselves enough evidence that they're safe. most of us don't act that way. Most of us kind of live our lives on the assumption that things are fine, things are safe, until we have a reason to be concerned that they're not. You don't go checking your locks and checking your stove. You don't go excessively washing. You don't go engaging in other rituals just because you can't prove to yourself that the stove isn't still on or the door isn't still unlocked unless you have some reason to think that it still is. The threshold is very different for people with OCD. And finally, not surprisingly, perfectionism can be woven into all of this as well. So that's kind of like a cognitive piece. What I was trying to illustrate with all of these is the part of the original picture over by the interpretation circle. So there are a lot of different styles and beliefs, some of which are pretty maladaptive, that fuel the way in which people maladaptively relate to their obsessional thoughts, which then causes them a lot of anxiety, of course, and leads to ritualization. But I also want to tell you about the behavioral way of conceptualizing this, and it goes back to Maurer's two-process or two-factor theory of avoidance learning. And essentially, the assertion is that at some point, for whatever reason, a neutral stimulus becomes associated with anxiety. There's some sort of, I don't know, Pavlovian conditioning or whatever exactly happens. It's not usually important for us to have any guess even about what that is. For some reason, for example, touching a doorknob and contamination and, of course, associated anxiety become associated with each other for this person. And that itself is not enough. In fact, by the way, the evidence is not super strong to support that this is actually what happened. But from a conceptual point of view, for whatever reason, something caused these things to be associated with each other. But the second piece of how the OCD is maintained, really how it's almost created and then maintained over time, is that anxiety is reduced by the ritual or the compulsion. And that's what we call negative reinforcement. The example people like to give for negative reinforcement is when you buckle your seatbelt when you get into your car, it gets that annoying beeping noise to stop. You're more likely to keep buckling. Well, it's the same thing. When you engage in a ritual that reduces your anxiety, you certainly prevent yourself from being able to learn what would happen if you didn't do the ritual, et cetera, but you are negatively reinforcing the compulsion. And so we've got two problems, one really a problem of classical conditioning and one really a problem of operant conditioning. The first problem is that for whatever reason, we have some sort of neutral stimulus that's now associated with something like contamination and with the distress that comes with that. And the second problem we have is a cycle where the individual with OCD, by ritualizing and by avoiding and by getting reassurance, which essentially functions the same way, all the stuff that people do to reduce their anxiety negatively reinforces the cycle. So they're going to be now more likely to freak out in response to the obsession next time, and also more likely, if they do feel, say, contaminated, to engage in a compulsion again. And this just fuels the whole cycle. So if we could put all of what I've told you then together into one model, and for a moment I'm going to ask you to ignore, I know it's a busy slide, I'm going to ask you to ignore the two circles on the sides, and let's just talk about the middle section for a moment. What happens is we start off with an intrusive thought. The middle section is similar to that first circle that I showed you. You start off with an intrusive thought, and that is then associated for some people with maladaptive interpretations. I'll give you a concrete example in just a moment, which feeds back to having more intrusive thoughts. So you have a little bit of a bidirectional cycle over here. But when somebody makes one of these maladaptive, or several of these maladaptive interpretations, that also causes negative emotions. It causes fear, anxiety, maybe sadness, shame, embarrassment, guilt, whatever it causes. And people try to cope with those negative feelings. If you really get a strong fear response, you're going to do something about it, usually. And the problem here is that people engage in maladaptive coping strategies. They do things like rituals and avoidance. And that's really that behavioral piece I was just talking about. It becomes very negatively reinforcing, but it also leads right back in and feeds right back into the maladaptive interpretations. So one example of that is there are studies that demonstrate that when people engage in repeated checking, let's say checking a stove to make sure it's off, somewhat ironically, they become less and less confident in their memory. And you would think that the reason you keep checking is to try to become more confident, right? You check again to be sure. That's why we usually check, right? But when people keep checking something, what they're kind of doing is giving themselves a vote of no confidence. They're almost training themselves not to trust their memory. And so that's one particular example of how a maladaptive coping strategy, they're doing something to try to make themselves feel better. Not only is it negatively reinforcing in a behavioral sense, but it feeds into the maladaptive interpretations about how their memory can't be trusted and they can't handle stuff, et cetera, et cetera. That's the middle piece. I just want to highlight for you on the sides here that, of course, life experiences contribute to the kinds of interpretations you make. Whether you want to think about that in terms of early childhood life experiences or other ones, life experiences are a part of this as well, as are, on the left side, personality traits, core beliefs, belief domains, et cetera. And so let me give you an example of a particular woman, and we'll fill in this model thinking about some of her symptoms. Here's a woman who has a baby, and in the postpartum, she starts obsessing about harming the baby. Not very uncommon for people with OCD. So she has thoughts like, I might stab my baby, and she experiences an impulse that she doesn't like and fights and is not interested in doing, but she experiences an impulse to harm the baby. And if she would just treat that as neural noise, that would probably be the end of it. But if she makes interpretations that are something like, I want to do this, I'm at risk for losing control, and good mothers don't think like this, first of all, those things are likely to perpetuate those kind of impulses and thoughts. But also, you can imagine she's not going to feel great about that. So if she's having these thoughts and believes that good mothers don't think like that, and she's at risk for losing control, and the fact that she's thinking it means she wants to do it, she's going to have anxiety, guilt, and shame. She's going to do something to try to deal with those, and if what she does is avoiding knives and sharp objects, it's not uncommon for people who have these kinds of obsessions to not allow knives in their house at all. Engage in reassurance seeking from her husband, and check that the baby's okay a lot of times. Well, in the short run, that's going to reduce her anxiety, guilt, and shame. But in the long run, it's going to be negatively reinforcing, and it's also going to feed back to her beliefs that good mothers shouldn't think like that, don't think like that. She's actually at risk. Maybe she actually wants to do it because she's behaving in a way that's reinforcing all of that. As I mentioned before, the maladaptive interpretations don't occur in a vacuum. And for example, if this woman was taught growing up that thinking bad thoughts is sinful, totally out of this context even, she may be predisposed, if she does have these kinds of thoughts, to interpret them as a problem. She's been taught that thinking something is problematic. Strict, hard-to-please mother. And also on the other side, some of those other domains that I mentioned before might be at play as well. The importance of thoughts. You can see the thought-action fusion kind of importance of thoughts playing a role here, where she's thinking that she's interpreting her thoughts as being very significant and revealing what she could do, what she really is like. Responsibility, overestimation of threat, maybe perfectionism. We could go on over there. I don't want to spend too much time on that part of the model. So that's kind of putting together the behavioral and the cognitive pieces. I've now covered what OCD is and how we think about it from a CBT perspective. And I'd like to try to now shift into actually how do you implement the treatment. And what you're going to see is that the treatment is very, very much and very closely based on the CBT conceptualization of what's maintaining the symptoms. Recall that two-factor or two-process theory, the behavioral conceptualization of how anxiety is developed and maintained. It maps quite closely onto the actual DSM symptoms here and description of what obsessions and compulsions are. So the premise is that obsessions cause anxiety and compulsions reduce anxiety. And so the goal of treatment very clearly is going to be to break the bonds between the obsessions causing anxiety and the compulsions reducing anxiety. It's really directly getting at those pathways. And the way we're going to do this, very broadly speaking, and then we'll break it down, is we're going to do prolonged exposure with response prevention, ERP or EXRP, exposure and response prevention. We're going to sustain exposure to the obsession while preventing the compulsion. And what that's going to do is people are going to find that their anxiety will come down even without the compulsion. So obsessions don't have to be associated with never-ending anxiety. And they're going to learn that they don't need to rely on the compulsions to reduce the anxiety because they'll come down anyway. The treatment is not going to focus a lot on the development of why somebody has the particular types of fears that they have, unless the patient brings it up or it seems important, or on the etiological history. We're not going to, as this cartoon is illustrating, we're not going to ask people to begin with their mother. And it's going to be very, very symptom and present focused. We're not going to worry about etiology. We're going to worry about maintenance factors. And we're going to work on the assumption that if we can break the factors and the behaviors and maybe even adjust some of the beliefs and interpretations that are maintaining the OCD, then that will cause a lot of improvement. And we're not going to need to understand why, especially from like a dynamic perspective or a developmental perspective, why it started. Before I tell you about how to do ERP, I'm going to show you just a couple slides of data to try to convince you quickly that ERP is very efficacious. Here's one study. This is a study published by Edna Foa and colleagues in 2005, in which they compared intensive treatment, intensive exposure and response prevention, that's the orange line, to clomipramine, which is probably the first line pharmacological treatment for OCD, to a third condition where people received both ERP and clomipramine, to a pill placebo condition. And what you need to know about this study is that it was intensive, meaning that they gave treatment for 2 hours every day for 3 weeks, every weekday for 3 weeks. So you're talking about 15 straight business days where people are having 2-hour sessions. And then they're starting to space it out a little bit more. So what you see here on the x-axis is the weeks, assessment point in weeks. And by week 4, you've seen that everybody's gotten way better. But that's because it was a really intense, it wasn't 4 sessions later or 3 sessions later, it was like 15 or 16 sessions later. So it was basically at post-treatment. And then there's some follow-up and long-term data. Basically, the points I'm trying to make for you here is that ERP in this study, ERP, whether by itself or in combination with clomipramine, worked really well and beat both clomipramine alone and placebo. And so ERP is really a first-line treatment. It probably, for most people, maybe there are individual differences, for most people on average, there's no reason to think that just because you have severe OCD, you have to have some sort of med for it. ERP by itself or in combination looks about the same. And so it's a first-line treatment for OCD with or without concomitant pharmacotherapy. Lest you think that this is just something, an Ivy Tower kind of study kind of result with a clean sample, here is some data using a regular outpatient non-study sample and benchmarking the results from that treatment against some of the clinical trials that have been conducted. On the left side here, what you can see are the pre- and post-Y-box scores for these outpatients who are not part of a study. And there are 100 of them in this clinic. And what you see is something that looks almost the same as the results pre and post for all these other behavioral treatment studies. And so there's no reason to think that there's something special about treatment cohorts, study cohorts rather. This is something that, in terms of effectiveness research, works out there too. In terms of percentages of people who get better, people who can complete ERP, complete a course of ERP, in the FOA study over here, for example, 85% of completers met criteria for clinically significant change at post-treatment. So if they can go through with it, it has tremendous, tremendous benefit, and it certainly can. I'll add on that the caveat is it's a very difficult treatment. It's a tough treatment, and there are a lot of people who have trouble getting themselves motivated to engage in it, and there are some people who drop out of it because it's grueling. And so 85% of people who complete it do really well, but a lot of people have trouble with it. So in fairness, I want to say that. OK, so just a real quick review of what exposure is, exposure treatment. This is really the same exposure treatment you know and love from other anxiety disorders. What happens if, on the left side here, you see a curve. What happens if somebody goes into a situation where their anxiety is triggered? If it was a phobia, a spider phobia, they walk into a room and there's a spider. With OCD, it's triggered in some other kind of way. Their anxiety, if this is their anxiety on the y-axis, their anxiety starts to rise. And it goes up. And what usually happens outside of the context of treatment is that at some point it seems unbearable to the person, and they do something about it. And so, for example, they may leave the situation, or they may wash their hands, or they may do whatever rituals they do. And the effect of that, let's say at this point over here, somebody does a ritual or leaves the room or avoids. What happens with their anxiety? Well, their anxiety comes down. Maybe not immediately, but it comes down. The problem is that it's reinforcing the cycle, and the next time they encounter a similar trigger, it's going to go right back up again, and they're going to ritualize again. And you basically are in a never-ending cycle, maybe even an intensifying cycle, of exposure to whatever the trigger is leading to anxiety. What would happen, though, if they stayed in the exposure, or they were triggered, they got anxious, and they didn't do anything about it? What would happen is that their anxiety would peak at some point, because just physiologically even, their bodies can't maintain that kind of response, a fight or flight autonomic nervous system arousal thing. Their anxiety at some point would peak and would come down. It would be more unpleasant in the short run because it would go higher and stay around longer, but at some point it would come down. And if they did this repeatedly, where they faced their fear and didn't escape or ritualize, then the next time we're thinking, it's not that it would be all gone. The next time their anxiety would rise, but would peak a little bit lower and come down a little faster. And the time after that, a little bit faster and a little bit faster, until for a couple of weeks engaging in this exposure, facing this fear, we're thinking that it's really not going to cause them so much anxiety anymore. So I could gradually expose myself to standing back toward the front of the platform at the train tracks, and I'll start becoming less and less anxious. That's the fundamental principle that we're going to use to do exposure with response prevention. It's so important to prevent the compulsions, because think about what would happen if somebody decided, okay, hey, listen, I'm going to face my fears, I'm going to do my exposure, somebody who's worried about contamination, and they go into the public bathroom if that's their trigger, and they touch whatever it is in the public bathroom that's their trigger, and they get really anxious, and then they Purell. Well, they'd say, I did my exposure. What do you mean? I faced it. You did your exposure, but all you've done is reinforce the fact that you need to do your ritual as well. You haven't learned that nothing bad is going to happen, or that you can tolerate the anxiety or anything other than if you Purell, then you can. So it's very important to not engage in any kind of rituals, or you undo and maybe even worse than undo any positive effects from the exposure itself. Okay, so that's the basics in terms of the approach. I would say as well that from a therapist point of view, the goal of what you're trying to do, and what I try to communicate to my patients that my job is when we're doing ERP for OCD is, you pick whatever metaphor works for that person, but it's something like a player-coach kind of thing. I have some amount of expertise in these techniques in general about how to treat OCD and some experience with that. You have great expertise in your own experience. You're certainly the expert about what it's like for you and what happens for you. And what I can do is we can get together. I can kind of be your coach. I can give you ideas. I can help you scout the opponent, the OCD. I can find out the OCD's weaknesses. I can find out the OCD's weaknesses. I can find out your own weaknesses. So for example, if you need to work on being able to go left more, using a basketball analogy, then we can practice that, because that might be one of your weaknesses. We can try to come together with a game plan. But at the end of the day, you need to actually implement the game plan on the field. So it does no good for me to just talk you out of it or try to. It won't work. There's nothing that I can actually do to throw the ball, to shoot the ball, or whatever it is. I can help you design a plan that you'll be able to implement in a way that will work for you. That's the kind of relationship. So it's very collaborative. There's the general CBT, collaborative empiricism kind of approach. We're going to check things out. We're going to learn together. We're going to come up with a game plan together. There's not a lot of sort of interpretation. There's not a lot of stuff that's not transparent, frankly. And in fact, we'd get concerned when we see people who are struggling a lot with the compulsion, with the exposures, and with giving up their compulsions. One thing that comes to mind is maybe they're not quite understanding, or maybe they're not quite on board with the rationale. So everything is very transparent. We always start off with a good conceptualization and treatment plan, which requires a good assessment. That's probably true for every disorder. For OCD, it may be especially important for several reasons. Many people with OCD are not aware of all of their symptoms. That's one thing. A second thing is that many people with OCD have a lot of shame about some of their symptoms. And so they may not feel comfortable just bringing up out of the blue, I have intrusive thoughts of having sex with my sister. And if you don't do a careful assessment, you could be missing important pieces. It's also really, really helpful for rapport building, I find, because you have people who are suffering silently a lot of times. People have not recognized what's going on. They're ashamed of it, et cetera, et cetera. And if you can ask the right questions, sometimes even just using checklists, you can demonstrate an understanding of what's going on for them. And what it must be like for them, and even recognizing the symptoms that even if they hadn't recognized them, that goes so far in terms of rapport, just being understood about this thing that seems so bizarre, so weird, and so hard to control. So I think that with OCD especially, really careful, even kind of boring, structured interviews and assessments can be very helpful, and even rapport building. Some people worry that that'll be rapport destroying. So certainly there's the general clinician interviews that cover diagnoses, things like the SCID, things like the ADIS, which is an anxiety disorder specific measure. But I want to tell you just a few words about the Y-box. The Y-box, the Yale-Brown Obsessive Compulsive Scale, the Y-box is the gold standard measure for OCD. And the way it works is as follows. There's a checklist of symptoms, of typical obsessions and then typical compulsions. And you spend time, you go through all these and you ask people, have you ever had this kind of thing? And they're organized into categories. For example, there's a whole category of various kinds of contamination obsessions. Say, do you worry about germs? Do you worry about your bodily secretions, urine and feces? And then there's a section with, say, aggressive obsessions, et cetera, et cetera. Anyway, the point is that there's a list. And you go through the list and find out whether or not they've experienced these, whether they're experiencing them currently in the past and that sort of thing. And a lot of times it's useful because you uncover and you discover stuff. It helps teach them as well to distinguish between obsessions and compulsions. And it gives them a lot of just reassurance about this is a thing. This is a thing that we know about. So when I ask people, hey, have you ever had any obsessions about inappropriate sexual engaging in inappropriate sexual acts with family members or those kinds of questions, I think that people get the message, hey, this is on a list. This is something that people know about, and it takes away some of the shame as well, gives them permission. Then after you go through the whole checklist, there's a set of questions that are rating the severity of some of the symptoms. So, how much of your time is this taking up kind of questions, how much does this distress you, how much are you able to resist it kind of questions, and you get a score. The score ranges from 0 to 40. That's not super important for our purposes right now. But I definitely would advocate for using the Y box, especially the checklist toward the beginning, even if it feels a little dry for somebody not used to reading off of a measure like that. Some important differentials to consider when you're diagnosing and assessing OCD. So in terms of impulse control disorders, there's a difference between impulsive and compulsive. Impulsive, as I was mentioning before, impulsive would be something that has a pleasurable component to it. So people might feel like they can't hold themselves back from doing it, gambling, picking, pulling, that sort of thing. Excuse me. But there's some positive thing associated with that. People with compulsions tend to really absolutely hate doing the compulsions. They cause them a lot of distress. It's just the only thing that they're able to do to manage their anxiety. So that's one important differential. Another one is with tics. Tics and tic disorders are associated in the sense that there are higher comorbidity rates with OCD. With tics, though, we usually find that they're not aimed at neutralizing in particular, as opposed to the compulsions usually in OCD, and they're not really experienced as voluntary or as intentional in the same kind of way as compulsions. There are some types of compulsions with not just right feelings that start to seem a little bit closer to the tic kind of things, but there's that important difference as well. With GAD, I highlighted for you earlier some of the differences between obsessions and worry, so I'm not going to rehash that. They're very similar in the sense that there's a lot of thoughts that people can't stop and can't get control of and feel anxiety about, but there's some important differences as well. But I really also, aside from these particular common differentials, I want to emphasize again the importance of doing a careful functional analysis and evaluation of what's going on with the patient. With an example, so there was a patient who was severely underweight. This was a middle-aged woman with a family. She was, let's say, middle-aged. I'm not sure exactly. And she was, I don't know, 5'4", 5'5", and weighed 80 pounds, 75 pounds, something incredibly unhealthy. You can imagine she was hospitalized for that. She was also reporting that she was thinking about leaving her family, but she was very much struggling with that because she didn't want to leave them, but was still thinking about leaving them. It was kind of a complicated picture. And you would not be surprised, I think, to learn that people assumed that she had an eating disorder. But she actually said she had no problem with her body weight or shape or her body image. She recognized that she was severely underweight. And so it's kind of a puzzling thing. What it actually turns out is that she had OCD. She had scrupulous OCD, which is that form of OCD where the obsessional fears are religious or moral. And her fear was that being gluttonous is sinful. And she was not confident about where the line would be. How much can I eat that would be gluttonous? And so her OCD really latched onto this issue, and she would starve herself beyond the most unbelievably small minimum amount, rather than to risk the possibility of sinning, of offending God, of doing something terrible. She engaged in behavior that she knew was damaging to her body because to her, the fear of sin in that context was too great. And so it was actually a symptom of OCD. That was actually also why she was thinking about leaving her family. She was obsessing about whether or not God wanted her to become a nun. And she loved her family, she loved her husband, she had a good relationship, she didn't want to leave, but her OCD fears about the possibility of not doing the right thing in God's eyes, of sinning and of offending God, were causing her to engage in these behaviors. So what looked like maybe marital distress and an eating disorder was in fact OCD. all of which you would only know if you really carefully asked and examined, what is it? What's going on? Why do you want to do that? What are you afraid of? What would be so bad about that? And really did a careful functional analysis about what was behind the observed behavior. The structure of ERP, really, you can be flexible with this. Some of the studies use an intensive exposure plan, like I told you about before, where it could be for 3 weeks every single day, and then maybe a couple spaced out after that. So it could be really intensive, like daily kind of intensive. That's something that if you can manage to use it with your schedule, that can work really fast for people. You get a lot of momentum when people are constantly spending full time essentially working on this. And also if people don't have access to care and they can come to a specialist who can work with them from out of town, let's say, it might be beneficial to be able to pack it all into a certain amount of time. But some treatments, sometimes they do ERP twice a week, sometimes once a week. They all work. Certainly intensive can be better for people who are more severe and need more help getting traction with it. But there aren't rules that say you couldn't be seen once a week usually. There are a couple of residential centers as well that specialize in treating OCD, but I'm not going to get into that right now. So basically it could be intensive, it could be weekly. I know for most people weekly sessions is the most reasonable thing given other kinds of constraints. Sessions can be about an hour to 2 hours. If you can get more time to block for a session, you can get more done. You can go further with the exposures, et cetera. But if not, 1 hour sessions every week, which I think is probably what most people are used to doing in their practices, is something that for many or most people with OCD is going to be sufficient. Usually about 16, 17 sessions would be the default. Some people, I had one person who terminated after 6 sessions, even though she didn't start off so mild either. She terminated after 6 sessions because she really felt like she didn't need to keep working on stuff with me. So it could go really much faster than 16 or 17 sessions. Certainly that's not the norm to go that fast. And some people need a lot more than that. So I'm just giving you a heuristic guideline. That's kind of how the protocol would be written. And there's a lot of out-of-office work. There's a lot of homework for the patients to do. They have to generalize the ability to tolerate the fears and to face their fears outside of the office in their natural environments for reasons that just have to do with associative learning. It's not uncommon for people, even if they're in residential treatment and make progress in residential treatment, to then go back to their home environment and all of a sudden lose a lot of the gains. So you really want to generalize, but also for many people, the main triggers and the main obsessions and the main compulsions as well really occur in their home or with their kids or in other kinds of environments. So there's a lot of stuff they have to do outside the office, but it also means that usually the therapist, whatever their constraints are for different kinds of reasons, the therapist would do best if they can also, at least some of the time, be able to get out of the office with people. So I've done exposures with people in public bathrooms, in the infectious disease clinic at a hospital, on the streets, on public benches, in people's houses. If you can do these things, given whatever your constraints are, it's going to be a lot easier. You're going to be able to get further and help generalize the work for the patient that they're doing. And if not, certainly either way, they're going to be having to do all this stuff in their lives. So it's not, you wouldn't learn Italian by coming to class once a week and not working on it all week. You also can't break years of habits and fear by just coming into session, working on it for an hour or two once a week. So ERP. Let's actually break down some of the components of ERP and elaborate a little more. I've already told you that it's basically exposure and response prevention, but let me talk to you about some of those components in more detail. Self-monitoring, we're going to start with self-monitoring. And so usually after doing an assessment and helping conceptualize with a patient how I think about this, generally speaking, and getting them on board and discussing all of that, I'm going to ask them to self-monitor. And they can do this in a form that you can get from a lot of different sources and different books and workbooks, or you can create your own. I'm going to ask them to monitor essentially every time they catch themselves doing a ritual or a compulsion. And they're just going to note what they did, how long they did it, and maybe a couple other things about the situation. I'm not asking them to keep a long paragraph style log for each of these things. Just like one quick line, something that they can fill out quickly and just tally and keep track of when and why, what the triggers are, trigger situation, maybe the thought they had, the compulsion they did, and how long it took them, real fast. And it's best if they can do it in real time, sort of when it happens, because at the end of the day, sitting back and trying to reflect, you're going to miss a lot of important information. And this accomplishes a lot of things. It obviously helps you construct and conceptualize what you want to do in terms of intervention, in terms of both cognitive and behavioral interventions, where we need to target this, what this problem looks like, how much of your day it's taking up. It's also very motivating. A lot of times patients, when they're struck by having to keep a tally mark, and they're struck by actually having to look at it on paper, it's like, wow, I'm doing that a lot. And sometimes it can actually help people reduce the behavior. In the same way that in other disorders, like with eating disorders, or when people are actually trying to lose weight with obesity, people keep food logs in various kinds of ways that are helpful, not unhelpful, because tallying and keeping track can be very helpful. So in terms of psychoeducation, it's really crucial that up front you convey the rationale, you let the patient know what this is going to involve and why. They get a chance to talk to you about it. A lot of times patients will say, hey, I'm exposed all the time in my life. This is always happening and I'm still freaked out about it. How is this going to be different? And you're going to talk to them about how it's going to be different. Usually it happens when they're not having a sense of control and purpose. So for example, if you go to the doctor and you need to get a shot, I imagine that you would be willing to roll up your sleeve and allow the doctor to stick a piece of metal into your muscle. That's not a very pleasurable thing usually, but it's something that you can brace yourself to do if necessary. If you were walking down the street and somebody came up out of the blue and stuck a needle into your arm, that would be a very different kind of experience. That would be a traumatizing kind of experience. And so there's a huge difference, even given the same level of pain, discomfort, between choosing to face something difficult and having it happen to you haphazardly. That's one difference. It's also the case that they're probably doing unhelpful things like rituals along the way. So the point is it's going to be done differently, but you need to talk this all through at the beginning. You need to convey the model of OCD, personalize the model of OCD so the patient can see, help them generate it, so they can see an ideographic model of what's happening with their OCD and what's maintaining it and understand how they might go about breaking it. If I asked you to do the thing that you were most scared to do, I would expect that it would be very difficult for you. And there might be some hesitation, some lack of motivation, some ambivalence, whatever it would be. So it's no surprise, and it doesn't mean anything negative. We don't interpret it as something bad when a patient is struggling with motivation to face their biggest fears. It's really hard. If I asked you to do the thing that was hardest for you, you also would probably experience most of those same things and maybe even exhibit some of those same behaviors. So it's so important to help them build up the motivation to be willing to tolerate something very difficult for them, to be willing to face their fear, to see that there is hope, and to understand what and why you're asking them to do some of the things that you're asking them. So working on motivation, motivational interviewing, I don't have time to really go into that in a formal way. I'm sure many of you are familiar with motivational interviewing techniques. There's some studies that have begun to integrate that formally into protocols for OCD. But either way, I think most people who work a lot with OCD and do exposure and response prevention naturally end up doing a lot of motivational work and drawing on some of those fantastic skills from motivational interviewing in interacting with patients who naturally and understandably are really torn about their ability and their motivation to engage in this. I want to say I'm not going to talk about relaxation, and there's a that's purposeful. Relaxation, applied relaxation, and various muscle relaxation, breathing retraining, all those kinds of relaxation techniques are commonly used in the treatment of anxiety disorders, especially, for example, let's say with generalized anxiety. It's really a part of the CBT protocol. With OCD, relaxation is a control condition in the studies, and it doesn't work. It doesn't work for OCD. It certainly doesn't work well for OCD, and you run the risk of kind of undermining some of the message that you are sending to people as you're conveying to them that they can face their worst fears, they can tolerate and ride out their worst fears, and the anxiety will decrease. They'll learn that the feared consequences won't come true, etc. Teaching people to implement, especially contingent on the experience of anxiety or an obsession, teaching people to implement behavioral techniques to try to reduce their anxiety is a little bit of a mixed message. There are some times that there might be a worthwhile exception, maybe having people who have high baseline levels of anxiety just practice relaxation every day as soon as they wake up, not contingent upon any obsessions or anxiety. That might be different, but as a rule, we're not using relaxation to treat OCD. It's not going to be helpful for most people, and there's the danger of it being used in a really unhelpful, compulsive way. This is important to emphasize because actually there was a study published in 2004 in which they surveyed practitioners who treat anxiety disorders and identify as having a CBT approach to their treatment, and still within a group of CBT anxiety practitioners, more people endorsed using relaxation in the treatment of OCD than using exposure and response prevention in the treatment of OCD. And this exposure and response prevention is a first-line treatment for OCD. So I want to sort of correct that up front. I'm not going to go into it. Again, there may be some exceptions, but my default is we don't go to relaxation in the case of OCD. It's about tolerating risk and learning to tolerate risk and anxiety. Building a hierarchy. I thought what I would do is illustrate. I know that's really small. You're going to have some slides. I'll read off what I want to illustrate. I thought I'd illustrate with a couple of real patients that I've seen some of the hierarchies that we've built. And we can talk about how to do in vivo exposure with some examples. You know generally about in vivo exposure with things like phobias. We're going to make a graded list of things that cause people anxiety. We're going to rate it in terms of how much anxiety it causes them. And we'll be able to help them work up the list in terms of facing their fears, doing anxiety, until they habituate to the anxiety, although that may or may not be officially necessary, but doing exposures gradually, working up their hierarchy, and being able to face their fears more and more. So I thought with some specific OCD examples from real patients, this could be helpful, maybe embellished a little bit, either to make a point or to hide people's identity. When I'm ready to build a hierarchy, the patient and I are working together. They're on board, they understand the rationale for what we're going to do, they're motivated to do it, and we're ready to start. So that's the point at which we are now. And we're going to start by generating a list of situations where you get anxious because of OCD. Especially good if we can have situations where you would like to be able to do these things, or it would make sense for you to, but you're avoiding them, or they cause you a lot of anxiety because of OCD. And we're going to use the SUDS anchor, the subjective units of distress. So I might say either a 0 to 10 or 0 to 100. I might say, imagine 0, a rating of 0 on the SUDS means no anxiety at all, you're totally calm. Rating of 100 would mean full-blown panic, basically, the most anxious you can remember ever feeling. 50 right in between. And I'm going to ask people as they generate a list with me. I might throw out some suggestions if I have some ideas. But hopefully a lot of it is coming from them. I'm going to ask them to generate a list of exposure targets and ask them what their SUDS is. I like to do this actually on a computer in Excel. It's easy to sort, and then you have a pretty looking hierarchy. But however you do it, that's the idea. And this is very small, I know. Like I said, it's probably more items in this first example than you would need. You don't really need to have many, many items because it's going to generalize. Once people are able to comfortably face a 60 on their hierarchy, on a 0 to 100 scale in terms of SUDS, it's going to be easier for them to face lots of different 60s. And things that were previously 70s are going to seem more attainable, et cetera. So let me just read off a couple of examples. The first example, the first patient I'm going to show you a hierarchy and read you a few items from, is somebody who has fairly stereotypical kind of prototypical OCD. This is OCD about contamination. It's a mother. She's worried a lot about her family members, especially her child, getting sick in various kinds of ways from contamination. She's focused a lot on salmonella, bird flu related stuff. And so some of the items that she has, for example, her hundreds, she has 2 hundreds, meaning the worst possible thing, most anxiety she can imagine at the beginning of treatment. One of them was feeding bagged lettuce to her son. And that was around a time where there was some news that some bagged lettuce had been recalled because of, I think it was salmonella or something like that, some sort of infection or disease. And the second one that was also 100 was allowing her son to feed animals at the petting zoo for a similar reason. Some other items going down here, eating a bite of sushi was a 70. Going outside and not then bathing her son, that was also a 70. Shaking a stranger's hand was a 60. Allowing her father-in-law to kiss her child's hands was a 60 as well, 65 actually. Eating fruit without washing, it was a 40. Going to sleep without taking her son's pulse or temperature was something that would cause her only mild anxiety at 20, but you see the extent to which, all things equal, she was checking always on the safety of her child. And so we've got a huge spectrum here. Again, more items than you might need, but this is what she was generating, so we put it down. And you might start off anywhere on this hierarchy, to be honest, anywhere that the patient is ready to go. Now, obviously, if they can face things that are harder for them, they'll get more immediate bang for their buck. They'll get up the hierarchy faster if they can do things earlier that are harder. But if they want to start with the real easy things, that's fine too. It'll just take a little longer, and they can go a little slower. So by default, I usually start in the middle, 40, 50, 60 type ratings on the SUDS, which might mean that for her, I might ask her on our first exposure day if she might be willing to eat some bagged lettuce. For her, that was a 50. If she might be willing to take her son to the Philly Zoo. This was from the time I was in Philadelphia. Might be a 55 for her, something in the middle. But as a guideline, it's much more important that she's able to resist the compulsions when she's doing the exposure than that she'd do a very hard exposure. Because the compulsions are the big problem, not the obsessions. We're trying to induce, really, obsessions and fears, and we're trying to eliminate the compulsions, and that's what's going to break the cycle of OCD. And so I don't want to shoot for something that she's not fairly confident, we're not fairly confident we'll be able to complete as an exposure at first, and give her the experience of getting really anxious and then ritualizing. I would much rather start with something a lot easier, even if it's not going to be facing her biggest fears yet, but she's able to not ritualize. You also want to try to make, at whatever level of the hierarchy you've reached with a patient, you kind of want to make it so that their whole life is being lived at that level of fear. What do I mean by that? So if somebody would go and they would agree, they're worried about contamination, they would agree to touch something with one hand or with one finger. And we left it at that. What they're going to do is walk around the rest of the day, even if they didn't wash their hand, not touching anything with that hand. And so there's still kind of a lot of potential for avoidance. If they contaminate one room of their house, let's say they're worried about disease coming from something in the gutter, and so they take a rock out of the gutter, and as the exposure, they come and they touch it around the carpet in the living room. They're just going to avoid the living room, or at least they're going to be faced with that urge to avoid the living room. So much more useful would be, if they're not able to really contaminate their lives with a rock that comes from the gutter yet, would be to take something that's not quite as difficult on the hierarchy, maybe a rock that came from the front lawn but they never saw actually in the gutter, or whatever it would be, it would depend on the person, and really contaminate their whole lives with it. I mean, like, touch it to everything, touch it to their pillow, to their bed, to the inside, to their dishes, to their utensils, to the inside of the washer and the dryer. So it's not like they can even then go and wash everything afterward if they get seized by an impulse to do that, because it'll become recontaminated in the dryer on the way out. You want to make it so that somebody is immersed at whatever level they're ready to be immersed at, if possible, because that's the fastest way for them to get over it. If there's kind of no escape, and of course you're not doing it to them, they're on board with the decision that I'm ready to try this level. If they're immersed in whatever that level is of anxiety or of stimulus or trigger, they'll have to get over it fast, because they won't have the temptation or the ability to really escape it in the same kind of way. So that's a fairly straightforward kind of OCD presentation. I thought I would give you two that were a little different, just to illustrate how the same kind of principles would be applied even in a functionally identical way, even though the actual symptom presentation sounds like it could be very different. So here's another case. There was a young woman who had contamination concerns, but they had nothing to do with germs and sickness. Mostly nothing to do with that. There was a drop of that, actually, but I'm not going to talk about that. Her contamination concerns had to do with calories. And she was a bit of a bodybuilder, an amateur bodybuilder. And she obsessed in the same way that some people with contamination OCD concerns obsess about touching things that are going to make them sick or have germs or whatever it is. She had the same kind of fears about things, calories somehow getting contaminated with things. So for example, and you'll see some on the hierarchy, she did not like to go grocery shopping and pick up stuff for other people and put it in the same bag as her bag. She didn't even like to eat an apple that was on the same counter as further down the counter there was a cookie. Because although she recognized it was unreasonable, in the same way that people with other kinds of OCD usually recognize it's unreasonable, her fear had to do with somehow the calories getting into the apple from the cookie. Again, that sounds almost funnier, a little more bizarre or delusional, but it's not really very different from somebody who's worried about the contaminations of sickness and the germs. What if this touched that, and that touched that, and that touched that? So it's a very different kind of presentation, and I'll show you what we did in the hierarchy there. But you'll see really functionally it's the same thing. As long as you can conceptualize what's driving the fears, what she's doing to avoid or ritualize or get reassurance in order to neutralize or suppress the anxiety, you're playing the same game, and the treatment is essentially the same. So for here, her 100s at the beginning of treatment were, one of them was having an apple and a birthday cake touching, and then she just picks up the apple and eats it straight. That would make her incredibly anxious at the beginning of treatment. Having peanut butter, leaving peanut butter on her hands for 10 minutes, imagining who knows what's being soaked up by her hands in terms of oils, and then wiping it off, but not washing it, just wiping it off, picking up an apple and eating it. These were really hard for her. Going down the hierarchy, just so you see a few more examples, cooking pancakes on the burner next to egg whites. So sometimes she'd make herself just egg whites, and other people would be like, hey, can you do this? Or can I make breakfast next to you? Picking up cake with her bare hands and then eating an apple, but not actually having the two of them touch. Buying syrup, pancake mix, cake, and cookies and bagging it with her fruit at the grocery store, even if it was all packaged. That gave her a 60 on her 0 to 100 SUDS scale, et cetera, et cetera. So you get the idea. Cooking with her dad standing even next to her. Her dad, because he ate in a really unhealthy way, almost became a trigger of sort of calorie contamination for her. So what you're seeing here is it's really, we're doing the same thing. We're conceptualizing in the same way, however different or strange the particular details of OCD happen to be in this case. And in fact, my confession is when I started working with OCD and learning about OCD, I was really overwhelmed by the fact that it was just confusing and bizarre and people do weird things. But if you can kind of get past the details and just think functionally what's happening, then you're getting like sort of understand the rules of how OCD works, OCD's internal logic, so to speak. It all maps on. It's all the same thing. It's just for this person it's germs, for this person it's calories, for this person it's I might stab my kids, for this person is maybe I'm a child pedophile. So, but functionally it's all the same. I'll give you one last example that's kind of different. I mentioned a few times scrupulosity. A lot of clinicians have trouble working with scrupulosity because you have religion and cultural values so entangled with the OCD. So what do you do? Especially since in many cases the therapist is not of the same religion or religious observance as the patient. It becomes a very complicated kind of issue. And there's some evidence in some studies that it predicts poor treatment outcome, although some studies show that it doesn't. So that's a mixed group of evidence right there. But clinicians certainly sometimes have trouble with this. And what you're going to try to do is help the patient break and violate OCD law without violating religious law, because we're going to respect people's values and we're not going to try to say any more than saying that, that anybody who ever washes their hands is like doing something wrong. We're not going to try to say anybody who's engaging in religious ritual is doing something wrong either. So I thought I'd give you an example of a hierarchy I built with a certain young man who was an Orthodox Jew and had a lot of OCD that latched onto some of the rules of Jewish law. I'm not going to read it all because some of these would require a little bit of background explanation more than necessary for our purposes. So I'm not going to read through all of the particular exposures, but I'll bring out a few of them just to highlight. So for example, in Judaism, Jewish law doesn't allow one to mix milk and meat products. And so one of his most difficult things near the top of his hierarchy would be to pour milk on his hands, then wipe it off on a towel but not wash it thoroughly, and then pick up a piece of meat with his bare hands and eat it, which is something that technically is not forbidden in Jewish law, but he had a lot of anxiety about. Another one, if we move a couple down on the list, writing a paragraph where the letter T was not curled because he imagined that he was making a cross, and somehow that would be a violation of Jewish law because it's another religion. So he would always be very careful and actually sometimes review what he wrote to make sure that all the T's were sufficiently curled so he hadn't written crosses. That was another one. So writing out a sentence, a paragraph, whatever it would be, with his T's just as straight lines instead of curled. A couple other examples, lying to his father about something unimportant. He was worried that lying is something you can't do. It would be sinful. It would make him bad. So if you were dishonest. Throwing out a blank piece of paper without inspecting. So for him, a person is forbidden. It's considered disrespectful to throw out something that has a biblical verse written on it or God's name written on it. And he would inspect everything before he threw it out, any piece of paper, to make sure nobody had written anything like that on it. So just picking up a piece of paper that he knew was garbage somewhere and just throwing it in the garbage without checking it, that was something else on his hierarchy. One last example in the middle there, that's a 75. Here it was kind of weighted toward the top of his SUDS scale. There weren't that many items that caused him only mild anxiety. But learning a case of monetary obligation, speaking in the first person as a definite. What do I mean by that? I mean that he would study in his seminary, he would study cases that are in the legal Jewish literature. And the cases would be things like so-and-so borrows this amount of money from so-and-so, and then there's a dispute, and how do you resolve that kind of dispute? And the way people often would talk to illustrate these cases is by saying, okay, so let's say I go and I give you the following, and then you do this, and I say this. Maybe they don't even say the words let's say. Okay, so I do this, and then you do that, and they sort of speak out and articulate the cases as if they're speaking that they're doing it. He became very concerned that that would constitute sort of taking a vow or creating power, that if he would say, so I owe you $100, whatever it would be, then that would actually affect a requirement that he would then violate because he wouldn't even know that he was required to do it and wouldn't do it, and that would be sinful. So what I'm trying to show you here is it's really different in terms of the content. It's a different world of concerns. The fears are a very different kind of fears. But at the end of the day, we're still doing the same thing. We need to understand what the fear is. We need to get at the core fear. I'll get to that in a few minutes. And we need to generate a list of situations that would make him really anxious, but other people would be willing to do. The same way that if somebody's afraid of contracting HIV, we don't go sticking ourselves as an exposure with dirty needles, because sticking ourselves with dirty needles is something that actually is dangerous. Other people wouldn't take that level of risk. That's just foolish, essentially. But we would take risks, even if there is some risk involved that other people do take. So we would walk on the street with open-toed sandals, risking the possibility that there might be a dirty needle that somebody could step on, because people take that level of risk. Same thing here. We're doing the same thing. The other people who he affiliated with and associated with, his rabbis, the other students, they would do these kinds of things and not worry about it. And he wouldn't out of excessive fear. So we're designing a hierarchy in the same way to target those. So it really doesn't matter. You just have to attend to what the person's doing and functionally how it's operating, and you can create the same kind of thing. Okay. So in vivo exposure, a few more comments about it. I mentioned to you the importance of control and mastery, the difference between that needle at the doctor and that needle randomly on the street. The patient is always in control. You never do something to your patient. You never take it to the next level without getting their permission first. So if I was holding a contaminant or had access to one in the room, I would never just put it on my patient's lap or just hand it to him. I would first say, do you think that you're ready to do X, Y, or Z? I might encourage him or her as we went to go further. And I've done some things that some of you would find a little surprising, maybe, I don't know. But it's never to, you don't do anything to the patient. That's a very, very important thing. You also can't ever ask the patient to do something that you're not willing to do. And so I do exposures with the patient. Sometimes it almost doesn't make sense because it doesn't bother me at all. But for example, I have found myself, for some exposures, sitting on the floor of a public bathroom, eating Rolos straight off the floor with my patient. Do I like it? Not particularly. A little bit gross. Most of us don't do that. But I can't ask the patient to do it, and then I don't do it. What kind of message would that send? I also have to model the behavior. And so something to think about there is that we do, in exposure and response prevention, we do engage with our patients and ask them to engage in behavior that most people don't do all the time. But people would do if they had a reason for it. So even just like touching public toilets or touching the inside of a toilet, suppose we wanted to go that far. Maybe we would have to, maybe we'd be interested in going that far, maybe not. But even suppose going that far. Now, if I said to you, do you stick your hands in the toilet? Obviously, the answer is no. You may not even like to touch the seat of a public restroom toilet seat. But if I told you that your phone and your credit card fell into your toilet, would you stick your hand in and take it out? You wouldn't be happy about doing it, but you'd probably do it. You'd wash your hands afterward, but you'd be willing to do it. People don't eat off the floor often. So there's a lot of people who don't have OCD who drop something, and we all know the 5-second rule, but you drop something on the floor, and they end up throwing it out, especially if it's outside or something like that. But the truth is that most of us without OCD violate that all the time. So how many of us drop our pen on the floor at some point during the day, pick it up, and mindlessly end up biting on it or chewing on it or touching it to our mouth at some point while we're writing later on in the day? We do it all the time. People sit waiting for a ride on the stairs or on the curb, and they push themselves off with their hand on the ground. At some point later, they're eating potato chips and licking their fingers. If you're playing basketball, every single time the ball hits the ground, it's then on your fingers, and you're licking your fingers when you're ready to shoot or whatever. So we're asking patients to do stuff that, first of all, we don't always like to think about doing. But we do often inadvertently. As long as we don't think about it, we're OK with that. And sometimes we're asking them to do, and we'll do it with them, sometimes we're asking them to do and be willing to do things that most people don't do, but they would. And the patient has a reason to do it. So if people had a good enough reason, the reason is they're suffering with a life of OCD. That's another point I want to make as well. So we do overcorrect. We go further than most people typically go. And the logic behind that is there's a spectrum, there's a range of how comfortable people are with let's say germs, contamination kind of thing. There's a range among people without OCD, without any pathology. Some people are a little more finicky, some people are a little less so, and none of that is pathological. If you were really off of that to either side of the range, though, in either direction, it might be a problem for you. So if you were engaging in really risky behavior, really risky sexual behavior, or other behavior using dirty needles and that kind of thing, we would think we want to intervene. That's unhealthy. It's a problem, and we might actually have interventions to try to help people get back into the normal range. It's the same thing here. If people are overconsumed by off the normal range levels of concern about, say, contamination, then we want to help people get comfortable with being able to go all the way over to the other side of the healthy range, to be able to do stuff that pushes the limit a little bit, but other people would be willing to do. So obviously, we're not going to do unethical things, but pushes the limit a little. Not because I think that anybody is going to spend the rest of their lives touching things, eating Rolos off a bathroom floor, or doing a lot of the things that we might do as an exposure, whether extreme or even not as extreme. But because if they're able to do that, then all the regular stuff becomes easy. If you can eat Rolos off the public bathroom floor, then you could at least just go into a public bathroom and use it like everybody else. So we're going to do some overlearning and overcorrection. It was always taught to clinicians and patients that you have to stay in your exposures when you're doing in vivo exposure until the anxiety peaks and comes all the way down, or at least most of the way down, all the way to habituation. I just want to note in passing that recent studies show that it's less important within any particular exposure session that their anxiety comes all the way down than it is that over time, with repetitions, they're over time getting less anxious facing that fear. And so we're no longer necessarily, it's a good thing, it's helpful, people enjoy it, they feel like, okay, I can handle this, they get it, it's a good experience if their anxiety can go all the way down in the session. But the message has shifted away from being a message of stay in this exposure until you're not anxious anymore, to being more like stay in this exposure until you've learned whatever you need to learn. And that might be, I can tolerate anxiety. I can handle this. That could be a message for somebody that's sufficient. Okay. Here's just one quick example. It's a transcript right out of a chapter by Foe and Franklin, in which there's a discussion, a negotiation sort of, and a discussion between a therapist and a patient about the exposure and response prevention instructions. They had asked this patient who had contamination concerns to contaminate him or herself, we'll see the script in a minute, and to not shower for a few days, then to re-shower for 10 minutes, and then immediately recontaminate and not shower again for 3 days. Now, you're thinking, perhaps, that you shower more than every 3 days. So why so far? So here's the back and forth here that I think would be helpful to read. So to get you back to how you used to feel, says the therapist, we need to expose you directly to what you're afraid of. Now, there's a second part to treatment. I'm also going to ask you to not wash for 3 days at a stretch. No hand washing or showering for 3 days. Then you can take a shower, but you'll have to limit it to 10 minutes. After the shower, you'll have to contaminate yourself again, and then wait another 3 days for your next shower. Parenthetically, by the way, we usually don't require a full 3 days. It's usually not necessary. But anyway, to illustrate this, this kind of instructions. I can't believe it. I'll never be able to do that, says the patient. If I could, I wouldn't be here. How could I not wash? Every day I resolve to stop, but I always give in. You mean I won't be able to wash after I use the bathroom or before I eat? Other people wash after they use the toilet. Why can't I just wash less, like normal people do? Other people don't have OCD. Remember, for you, washing makes you feel less contaminated and less anxious, right? Yes. If you wash, even briefly, whenever you feel contaminated, you never get a chance to learn that the feeling of contamination would go away by itself without washing. If you're really very anxious, it might take a while, even several hours before you feel better, but it will eventually happen. On the other hand, if you wash, even briefly, every few hours, it will reinforce your idea that you have to wash to feel better. But why 3 days? Couldn't I shower once in a day like other people? For the same reason. You'll still feel relief even if you waited 24 hours between washings, and that would strengthen your belief that you need to decontaminate by washing yourself. You must learn to use soap and water to feel clean and fresh, but not to decontaminate yourself. So it's an extreme way of doing that, but the point is you have to learn to be able to, it's not that you'll never be able to wash like everybody else. First, you have to be able to break that association between needing to wash and decontaminating and not feeling anxious, and then you can get back to being able to use soap and water the way that it's healthy to use them. Okay, so that's with in vivo exposures. Let me tell you a little bit about imaginal exposures. Imaginal exposures is another technique that we sometimes use, usually in addition to in vivo exposures. Imaginal exposures are essentially, in vivo exposures, you're actually going and facing the fear sort of in real life. You're touching whatever it is that you're touching, or going wherever it is that you're going, saying whatever it is that you're saying. Sometimes, though, we're not able very easily to do that, and I'll tell you why. And we might engage instead in imaginal exposures where there's a story, there's a script that you create with a patient, and you can record that script. It's of a feared consequence, let's say, coming true, and they can do an exposure to the scene. So let me elaborate to what I mean by that. I imagine that you've all watched movies before, and maybe sometimes even had emotional reactions to movies. So have you ever felt a jolt of anxiety or fear? Had your heart start pounding while watching a scary movie? Or have you ever started to cry during a movie and felt sad or in some other way emotionally connected? Probably for many of you the answer is yes. And were you not aware that this was actors? Were you not aware that it was on a 2D screen, that there's directors in the background and all that kind of thing? Did you not notice that you're eating popcorn while you're watching it? It's not really happening. And you're aware of all those things on one level, but if a scenario, if a scene is engaging enough, it's realistic enough, and you can connect with it enough, it can activate your fears. And you can engage and sort of suspend reality enough that it can evoke all kinds of emotion. And that's certainly the case with personally relevant kinds of fears. And so as long as you can construct a scenario that involves enough of the senses, what are you thinking at the time, and smelling and seeing and hearing, and what's that person doing and what you're doing, as long as you can construct a scene that's like a movie scene where you can't see the director in the background, and it's not choppy, and it's something that you can engage in, it can activate somebody's fears. So for example, imagine somebody who has fears of doing some kind of exposure and getting cancer from doing that exposure 40 years later. You could do in vivo exposures to actually doing whatever it is they're afraid to do, but you're missing the ability to actually learn about whether the feared consequence will come true and get any kind of direct corrective information, because you wouldn't know it until 40 years from now. So you can't get at that feared consequence. Imagine somebody else who has impulses or images about stabbing their kids. Now, as an in vivo exposure, I might ask them to chop vegetables when their kids are home, but I can't very well ask them to stab their kids, and I wouldn't want to do that. If somebody has fears about going to hell because of sinning, I can ask them to engage in the behavior they're scared of doing, or we can find ways to do exposures, but we don't get to know now whether or not the person's going to go to hell or what that might look like. There's no way to access that. So in situations where you really can't access the feared consequence, it's not direct enough, you couldn't know one way or another, it would be unethical to do it, we might want to paint an imaginal scenario where you construct and where the patient constructs a scene where that all happens. So maybe it's the case that the scene goes something like, you know, I'm really anxious about chopping vegetables now. I brought a knife home. I need to fight my OCD. And I decide I can't give into it. As I take out the cucumber and stand there, my little kid walks into the room. And this would be done in a more realistic way. Starts talking to me. I get a surge of anxiety. I think, why am I taking this risk with my child's safety and health in order to do my own exposures? But I decide I can't give in to my OCD. I have to do this. And essentially, the scene plays out where, in fact, the person does get the impulse, does lose control, and does stab their kid. And all of the horrible sequelae, whatever they're most afraid of from that scenario, then plays out. I don't know if that's having to be at the funeral. I don't know if it's feeling responsible or being blamed for it. I don't know what the most deep core fear would be, but it all plays out. And you're going to do this in present tense, as if it's happening. It's going to be a scene that the person can listen to, engage in, and it can activate their fears. Maybe they'll read and record it if saying it in their own voice is most likely to work for them. Sometimes patients prefer that I read the scene to them after we construct it in the second person. So you are this, you are that, you're doing this, you think that. But it's going to be realistic, engage all the senses. It's going to be in the present tense. There's no need for gratuitous violence, though. So we don't have to, unless that's really an important part of the fear, we don't have to depict in graphic detail anything about the stabbing, for example. That's not the main point. It's not necessary for fear activation. So that's something about imaginal exposure. So those are the basic components of ERP. There's self-monitoring, psychoeducation, in vivo exposure, and imaginal exposure. And those are the building blocks, and you're going to put those together. What I want to do now is just spend a short amount of time telling you about some of the nuances, subtleties, and challenges that may come up, and just make a few points about how to implement these things that may not be just obvious from the techniques themselves. The first of them is the importance of core fears. I've told you a lot about functional analyses, and you always need to get at the person's core fear, and it's not always apparent what it is. So what do I mean by their core fear? The mother who's afraid that she might stab her children, what would be the worst thing about that? Well, that sounds like a silly question because stabbing your kids is, we all recognize how terrible that would be. But what is the thing about that that really scares her? Would it be her husband's reaction? Would it be waking up the next morning aware of what she did? Would it be being at the funeral? Would it be dying in jail? Would it be being ostracized? What is the worst thing? You have to target the core fear. Two different people can fear the same thing for very different reasons. And if your exposures, imaginal or in vivo, are not targeting the core of it, you may be missing the point. In the same way that if we were dealing with body image, the importance of eating in weight and shape with a woman who was starving herself, but was starving herself because she was worried about sinning, we're totally missing the point. Not everybody who's afraid of contamination and getting a disease is afraid that they're going to die as their core fear. I've had people who had fears of dying, and if I had left it at that, I would have been missing a big component of what made them so afraid and engaged so much in the rituals, because for one woman, for example, her biggest fear was that she would be responsible for leaving her children as orphans, and that they would grow up in a messed up kind of way and have all sorts of trouble. For her then, an imaginal scenario would have to take the consequences of whatever it is that she's thinking about doing to a consequence where her kids in fact end up messed up as adults in whatever ways she's picturing because she left them as an orphan. Because for her, the fear wasn't my death. The fear is the consequences on my kids. So we need to get at this and target it behaviorally, but one way to actually uncover the core fears is by using a technique called the downward arrow, which is a cognitive therapy technique, which is that when you're finding out and talking with somebody about what they're afraid of, what their obsessions are, et cetera, you always want to keep pushing with what would be the worst thing about that and what would be so bad about that until you've hit the end. And I know that it can sometimes seem strange, and sometimes I'll apologize as I'm doing it. I'll say, I know this sounds like a weird question to ask when you just told me you're afraid of dying. What would be the worst thing about dying? And if they say to me, well, that's it, that's the worst thing, then I'm there. But maybe that's not it. And so you have to uncover the real core fears. Doing that kind of analysis can sometimes help you problem solve difficulties in treatment. I know a therapist who was working with somebody who was having an intrusive image of his girlfriend being mauled by a shark. And he dove into the water in this image, in this obsessive image, and tried to save her and couldn't, and she was killed. And so they said, okay, we need to do exposures to this. We need to do imaginal exposures to this scenario. And so they did a lot of imaginal exposures, and the patient did not habituate and wasn't getting any less anxious about it. And this was very puzzling because it doesn't make sense. Why not? What they were able to identify, though, after a closer look, is that part of the patient's core fear was being a callous, bad person and not saving his girlfriend. And in fact, there was a part of that scene that transitioned from obsession to a mental compulsion. The shark is mauling her, and part of what was making him actually try to feel less anxious, strange to say, was the part jumping in and trying to save her. And so they modified the exposure so that he's imagining an image where she's being attacked by a shark. He's reading on the beach, looks up, sees it happening, and goes, oh well, and goes back to the reading. And they used that as the imaginal exposure, and in fact, the patient habituated fairly easily to that. And so identifying the core fear can be so important because they were missing at first the recognition that the real thing for the patient was me being such a person that I couldn't save her or that I didn't try to save her hard enough or well enough. And once they were able to incorporate that, they could separate the compulsion and the obsession. They could cut out the compulsion without cutting out the obsession, and it worked. people wonder about the use of cognitive techniques when you're doing exposure and response prevention. And so up front, I'll tell you that there's a growing literature demonstrating that cognitive therapy in and of itself can be helpful for OCD. I'm not talking about that now. I'm just talking about in the context of exposure and response prevention. If you can't see that slide, it says, and you know, realistically, it's much safer than driving with a patient there, a superhero who flies with a cape. And so one of the concerns with using cognitive techniques with people who have OCD is that it can become a reassurance-seeking, compulsive ritual kind of thing. They're already trying to talk themselves out of bad things. They're already trying to make sure that things can be okay. And too much focus on things like probability and that it's really not likely is fertile ground for compulsively engaging in reassurance and self-reassurance by trying to convince oneself that, no, this is just my OCD, it can't happen, where what we want to have is acceptance of the risk. We want to have tolerance of the uncertainty and the ability to live with an acceptable level of risk. So the main message here is to tread carefully. I do sometimes use cognitive techniques. I'm very mindful of the fact that they can be misused and what would be a good way to use them. I'll give you one personal example that I found helpful to use it with somebody. There was somebody who was really concerned about contracting various kinds of diseases from bodily fluids, especially HIV and AIDS. And so pretty standard kind of concerns for OCD. He, at one point, was doing pretty well in his treatment and decided that he was going to take a walk in the park without constantly scanning the ground for things that could be contaminated because he was going to fight. It was an exposure. He decided to do it on his own. It was great. Unlucky for him, I guess lucky for the sake of treatment, he actually stepped on a used condom while he was doing that. And you can imagine what his reaction to that was. And his shoe was very contaminated, and he ended up getting into the car. He had to go home at some point. And what had happened at that point, this was several weeks had passed, he had stepped in it with his shoe, he had stepped in his car with his shoe, and we were at this point talking about his keys. He had his car keys in session, and he felt that the car keys were still really contaminated. The reason they were contaminated is because they're used in the car. His shoe, which had touched the used condom, touched the car, and who knows what got transmitted how and how it traveled, and he was imagining contamination with his keys. We were trying to work out an exposure that would make sense for him. You can imagine some straightforward ones, but he was having trouble with it. And he finally said to me, he said, look, I've been living like this for so long that I don't have a good sense of what's normal and what's not. I don't know the HIV virus, how long can it live? How long can it live on an inanimate object? Like, is this even, I don't know if it's possible, and I'm telling you it's not just an OCD thing. I genuinely don't know. And I got the sense it wasn't a reassurance thing. It was just assurance, meaning we hadn't gone over this before. He wasn't repeatedly trying to reassure himself. He just wanted to know some basic information. And so what we did is I agreed, before we looked anything up, I said, well, how about this? Why don't we find a place to look up that information if you can agree beforehand that if the information, the reliable information we find says that you can't contract HIV in this way, then you'll do the exposure, which was, I don't remember what, touching the food to the keys and eating it or something like that. And so he agreed to that, and we looked it up. There's a helpful website at one of the medical school, big academic research medical centers, going through questions like this, actually, educating about HIV. And obviously, it's totally impossible. The HIV virus, even in very high concentrations, as they use in studies, doesn't live very long on an inanimate object. There's no way. And to me, the biggest sign that this was not a mistake to do this is he still had the same level of anxiety about doing it afterward, about doing the exposure after we looked it up. But he had the decision and the permission and the motivation to go ahead with it anyway. So he was able to use the cognitive technique, getting some education actually in this case, not so much of a cognitive technique, but having to do with probability. He was able to use that to make a decision about whether it's just his OCD preventing him and his anxiety preventing him from doing this, or whether it's a legitimate kind of fear. And once he saw that, in fact, it must be an OCD fear, it's not a legit fear, he didn't become less anxious, so it didn't work as a compulsion, but he was willing and able to actually face the fear and do the exposure. And so the main message, I guess, that I'm saying is that I think cognitive techniques can be really helpful, especially if they're in service of having somebody be willing to face the fears. They can test out some of their hypotheses and learn. They can find out if they can really tolerate the fear, as opposed to being used in a way to convince themselves that everything is safe. That would be what you'd be concerned about. Just a couple more slides I'm going to go through real fast. In terms of challenging cases, sometimes a patient is unable to resist the compulsions. What do you do then? They can't not hand wash. They just can't get it. It's severe enough or they're unwilling to or something like that. So I'm just going to suggest you can also mess up the ritual. If they can't altogether prevent it from happening, an intermediate step might be, well, if they wash for 5 minutes with scalding water and they have a particular order for how they wash, what about washing for 2 minutes out of order in lukewarm water? And so you can, if somebody can't do full response prevention, there are ways to try to mess up in working toward being able to eliminate the rituals as well. Mental rituals, a couple more comments about them because I have talked about them and I've talked about scrupulosity before. There's one thing I haven't said yet though, which is that not thinking in obsession, as I've told you, doesn't work real well. The white bear thing, thought suppression, doesn't work when it comes to obsession. So we tell patients, if you want to think about something less, think about it more. So don't avoid your obsessions. It doesn't work. It keeps them around longer. Well, you know, the problem is that there's a little bit of truth to that for mental compulsions too. If I ask somebody to not do a mental compulsion, not picture wiping away the bad thought, not replacing it with a good thought, I'm also asking them to not have a certain kind of thought. And there are some patients who are not able to do that because they get caught up in the same thought suppression game and they can't keep themselves from having a thought on cue, even if the thought is compulsive or a ritual. So I want to make a couple suggestions that you might do in a situation like that. I think that any way in which you can make the response prevention active instead of passive is to everybody's benefit. What do I mean by that? Instead of saying, I'm not going to think it's going to be okay. I can't think it's going to be okay. I can't replace it with a good thought. I can't do a mental ritual. Have them articulate actively the uncertainty. So instead of saying it's going to be okay in their mind, or trying to hold themselves back from that thought, have them articulate out loud, I might actually get a disease from this. Probably not necessary to say I will, because their fear isn't that they will, their fear is that they might. Similarly, if somebody is doing rituals about having to do with being evil and offending God, so instead of just not doing rituals where they mentally think good thoughts or something like that, have them speak out or in some active way say, I may be evil, I can't know. Or I'm going to take the risk that this might be wrong anyway in the face of my anxiety. Anything you can do to make it more active. Sometimes it could even just be if somebody has a ritual that they can't resist counting in their head as they're walking on stairs, 1, 2, 3, 4, 5, the stairs. So I've had people sometimes mess that up by counting backwards from 1,000 by sevens, where they just don't have the cognitive resources to do both. You have to be on the lookout. That itself doesn't become a ritual, but it usually won't. The point is make it active if you're trying to have people resist mental rituals. And finally, a couple things about concerns that people bring up in relapse prevention. Sometimes people are concerned about the ethics of some of what we do in ERP. And so there is a question about how much is too much. I think, again, as I mentioned before, I'm going to encourage patients to do things that even if I don't usually do, I would do and I do with them. If you're going beyond that, you might want to question a little bit. But there's also ethics about things like some of the in vivo exposures. Sometimes people are concerned, well, if I have somebody who's afraid that they might be a pedophile, and then I have them, I don't know what it would be, I have them walk past kids in the supermarket instead of usually if they see a kid in that aisle, they avoid the whole aisle till the kid's gone. Now they're not going to. Or I have somebody chop vegetables with a knife, and they're having intrusive thoughts that they might stab their kids. Oh my God, what if? So the answer to that is really, obviously this is all predicated on the assumption that careful assessment has indicated that this person is not a pedophile. These are not fantasies or enjoyable thoughts, that this person doesn't have a history of violence and all those kinds of things. Assuming that we're really dealing with OCD, though, and you've carefully made that determination, a person who's having obsessions about maybe stabbing their kids and is freaking out with anxiety about it is no more likely to stab their kids than a person with this intense snake phobia is likely, if you keep them in a room with a snake in a cage, to run over to that cage, lift up the lid, and start playing with the snake. That's the thing they're most terrified of. So you have to sort of conceptualize, assuming that it's really OCD, what the person is telling you is their biggest fear. The same way that with a phobia, something is their biggest fear. I think they're probably the least likely people to go ahead and do something like that. The other question that sometimes comes up, I think, is what if people really do get sick? If people really do get sick, for example, if we do contamination exposures and they really get sick. And what I would say about that is that, first of all, there's a question of the the relative suffering from living your whole life with OCD and maybe getting the flu twice a year because you're being a little more careless, so to speak, even if that would be the case. But let's say also somebody says, well, you know, I don't want to go around touching stuff in the emergency room as an exposure. It's February and there's a lot of sick people. Maybe I'll get sick. And you're going to do that exposure. What if they then do get sick? So you do the exposure and they do get sick. Does that blow everything up? Does that ruin everything? And so I would suggest that you have a discussion with patients before the exposures about what to expect and just general base rates. So I was in the Northeast before, and in the winter, if we did exposures that people were afraid they might get sick, I mean, they might get sick in the next week having nothing to do with it. And they might get sick 3 weeks later. Would you say then it's because of this exposure? So you need to set up the interpretation beforehand so it doesn't come across to the patient as some post hoc rationalization. Oh, I did get sick. See, I'm right. Oh, but you're just going to tell me that, oh, it's just because of chance. It has nothing to do with the exposure. You want to have those discussions beforehand so it's clear how we're going to interpret this. If you say this, you're worried about a terrible thing happening to your sister. When? In the next 24 hours or within the next 15 years? Because what if something 14 years later happens to your sister? Are you going to attribute it to this, et cetera? So you want to just set it up before you do exposures. And then really the last thing to touch on is the importance of relapse prevention. People are going to have intrusive thoughts later on in their life. That doesn't mean they're relapsing, and they've already learned skills about how to handle those thoughts. And so you want to review with them what they've learned, what they would do if they notice that they're starting to engage in more avoidance, if they notice they're starting to obsess more, planning for the recurrence of symptoms in the past, teaching people to lean into anxiety, meaning if you have a chance, anytime you have a chance to do things one of two ways. One will violate your OCD, and one will not violate the OCD. Anytime you feel anxiety, instead of leaning away from it and trying to avoid it, find a way to lean into it. And you're sort of prophylactically maintaining your treatment approach over time and keeping it from recurring, as well as preparing for instances where it may recur on its own. I'm going to skip that second to last slide. It was just an example that you can look at on your own of a relapse prevention plan that a kid I worked with and I wrote down at the end of treatment. He wanted to take it with him to sort of have as a guide to look back on. And the last slide, I just want to give you my email address. You're welcome to contact me. I also want to make a quick pitch for the International OCD Foundation. It's a fantastic foundation with all kinds of resources. It supports treatment efforts, dissemination of knowledge, training, research. It's unbelievable. You can go to their website. You can see resources for clinicians, for patients, for family members. That you can find a therapist who's experienced in OCD through them. You can call them as well. They have a fantastic conference. So make yourself familiar, if you end up working with OCD, make yourself familiar with the International OCD Foundation, their website, and the resources they have available. Thank you very much.